Welcome to this lecture on amyloid PET brain imaging. It's been prepared by myself and Dr. Naomi Shea for the Australian Dementia Network. So dementia is now the leading cause of death and disability in Australians aged over 65. Alzheimer's disease causes about 70% of these cases of dementia. Alzheimer's and dementia in general is a challenging clinical diagnosis, and the wrong diagnosis is given to patients in about 30% of persons presenting with cognitive complaints. Disease-modifying therapies aimed at beta amyloid, the key component of Alzheimer's disease, have arrived, and this makes accurate diagnosis now more important than ever. Amyloid PET is a valuable adjunct to clinical and other diagnostic testing. And the US FDA did approve several amyloid imaging ligands, florbetaper, flutamidamol, and florbetaper, back in 2013 to 2016 to assist the diagnosis of Alzheimer's disease. The benefits of amyloid PET are improved diagnostic accuracy, particularly for Alzheimer's disease versus frontotemporal dementia. It allows earlier diagnosis of Alzheimer's disease in the mild cognitive impairment phase, or MCI. This is also known as prodromal AD, which is when patients have significant memory impairment and other cognitive findings, but are not significantly impaired in their day-to-day function. Amyloid PET also gives a 15 to 30-year window for the detection of preclinical Alzheimer's disease. So this is when the pathology of the disease is present, particular amyloid plaques, but symptoms have yet to emerge. Amyloid PET also allows improved subject selection for therapeutic trials, and it's extremely useful for measuring the effectiveness of anti-amyloid drugs. In 2014, the International Work Group published new criteria for the diagnosis of Alzheimer's disease to overcome the inaccuracies and the late stage of diagnosis made on clinical grounds. The criteria that were proposed were objective evidence of episodic memory impairment, such as impaired recall of a list of words, plus pathophysiological biomarker evidence for Alzheimer's disease. And this could be a positive amyloid PET scan or CSF analysis showing low A-beta 42 and high tau. This has led to the use of amyloid PET for diagnosis, and in 2013, a task force of the Alzheimer's Association and the US Society of Nuclear Medicine proposed appropriate use criteria. These were to be applied when a patient presents with a cognitive complaint and they have objectively confirmed impairment. When Alzheimer's disease is a possible diagnosis, but there is uncertainty after evaluation by a dementia expert, and when knowledge of the presence or absence of amyloid pathology is expected to increase diagnostic certainty. So these were the three big areas in which it was felt appropriate to use amyloid PET, given that this is quite an expensive investigation with somewhat restricted access. So early onset dementia, which is defined as onset of dementia before the age of 65. In these cases, AD clinical features are often atypical. A lot of psychiatric types of features are often present, and frontotemporal dementia is relatively common, and it can be very difficult to make the distinction. In mild cognitive impairment, 50% have Alzheimer's disease, 10% have other causes of dementia, but importantly, 40% do not progress to dementia. So when a patient presents with cognitive complaints, but they're still functionally impaired, so they don't meet the criteria for Alzheimer's disease, amyloid PET can help make a diagnosis of MCI due to AD or prodromal Alzheimer's disease. Dementia of uncertain cause after expert assessment is the third criteria that are felt to be appropriate for amyloid PET. And very recently, a new one has been added, and this is confirming the suitability for anti-amyloid monoclonal antibody therapy. So amyloid PET initially developed with carbon-11 PIB, but with the 20-minute half-life, access was restricted to production sites that had non-site cyclotron. The F18 labelled traces were soon developed, and these are now called florbetaben, florbetaper, flutometamol, and NAV4694. The sensitivity and specificity of these traces compared to post-mortem diagnosis of Alzheimer's disease is over 90%. When imaging florbetaper, the proposal is to use a black on white image. For florbetapen, it's a white on black. These are both read in grayscale. These traces do not work so well on a colour scale due to a fairly low distinction between cortical amyloid binding and non-specific white matter binding. Flutometamol, NAV4694 and PIB have greater affinity for amyloid plaques and therefore higher uptake in the cortex in positive cases, and are optimally read with a rainbow colour scale. But in reality, all traces can be read in the same grayscale, though reading may be easier in colour for those traces with higher amyloid affinity. So this is a negative and a positive PIB amyloid PET scan. On the left, you see non-specific binding to white matter. It's believed to be to myelin. On the right, we have extensive binding throughout cortex to the amyloid plaques, particularly in the frontal lobes, the posterior cingulate running back here along the top of the corpus callosum. The precuneus, which is the medial part of the posterior parietal lobe. Here we see the frontal cortex again, the posterior cingulate precuneus area, and the lateral parietal regions. You also see binding in the lateral temporal, and with the higher affinity traces, you also see it in the striatum or caudate nucleus of the basal ganglia. So these are the 3 FDA-approved traces and the recommended colour schemes for reading them. So florbetaben, a negative scan on the left. This is white on a black background, and you can see binding in white matter. On the right is a clearly positive scan with binding extending out the entire cortex. The next level is florbetaper with black on white background. Again, the non-specific white matter tracts are seen, and in the positive case, that impression is lost because the cortex is now taken up tracer as well. And this is a rainbow colour scale used for flutometamol. Negative scan, again, just white matter tracts, but in a positive scan, extensive uptake throughout cortex. These are the guidelines for scan acquisition and reading that have been previously published. So for NAV4694, which is not FDA approved, but is increasingly used in research sites and in some places for clinical application, a dose of about 200 megabecquerels is sufficient. This is about 5 millicuries. You wait 50 minutes from injection before you image for 20 minutes. Use a rainbow colour scale, and I recommend you normalise this to the cerebellar white matter, and I'll show you a bit more on how to do that. And positive scan criteria is cortical uptake. Flutometamol, also known as Vizamol, the product from GE Healthcare, 185 megabecquerels, again 5 millicuries, is the recommended dose. Uptake time is later. You have to wait 90 minutes, then do a 20-minute scan, rainbow colour scale, and then the makers suggest that this is normalised in colour to the PONS. And the positive scan criteria are one region of cortical uptake and the striatum, though not the occipital lobe, because there is an interesting phenomenon of occasional cases of isolated unilateral occipital lobe uptake of these traces not associated with amyloid anywhere else in the brain. So not quite sure of the cause of this observation, but these patients don't actually have Alzheimer's disease. Florbetapir, also known as Amyvid, is 370 megabecquerels or 10 millicuries. Uptake time is 50 minutes post-injection prior to scanning, again a 20-minute acquisition, and red in black on a white background, setting the maximal intensity to the brightest region of brain uptake. And for a positive scan, you need to see two regions, basically two lobar regions, where the uptake is in grey matter is equal to white matter, or one region if the uptake in grey matter is clearly greater than white matter. Florbetaben, also known as Neurosec, 300 megabecquerels, so about 8 millicuries. Again, a 90-minute uptake period, 20-minute scan, red-white on a black background, and they recommend using the white matter as the reference to setting your colour scale. Positive criteria is cortical uptake. For PIB, 550 megabecquerels, 50-minute uptake, 20-minute scan, rainbow, again normalised to cerebellar white matter and cortical uptake. So these are the parameters that have been used in most clinical trials. They provide the best SUVR, which is the ratio of cortical binding to cerebellar grey matter or whole cerebellum. No patient preparation is required for amyloid imaging. There is no need to fast, no need to withhold medications. And as mentioned, flutamidamol, florbetapir, and florbetaben have been approved for use in the USA and in Europe. In Australia, the situation is not quite so good. None of these traces have been listed with the Therapeutic Goods Administration, and there is no Medicare rebate for these studies. A limited number of centres, such as mine at Austin Health, do provide a service, but this does require a substantial patient co-payment. Amyloid PET is used widely in Australia for Alzheimer's trials and research studies, but this will all change once anti-amyloid therapies are approved, which may happen within the next year or two. So again, going through, here is a negative florbetapir scan on the left showing quite nice demonstration of the white matter tracts. And when you see this compared to neuropathology, it means there are sparse or no amyloid neuritic plaques present, and it has a very high negative predictive value for Alzheimer's disease. On the right is an abnormal florbetapir scan. You can see you've lost the white matter tracts because the grey matter is also filled in. This is abnormal and correlates with neuropathology findings of moderate to frequent amyloid neuritic plaques, and this increases the likelihood of Alzheimer's disease. Now, amyloid is a very slow process, the deposition, that is. It, in fact, occurs over about 30 years from when amyloid plaques first start to form to when you reach the level found in typical cases of Alzheimer's disease. So this is a scale that we have previously published, a model from 2013 in Lancet Neurology, illustrating there is a 10-year period of accumulation before you get to the appearance of a positive scan, and this is just faintly positive on amyloid PET. Then another 20 years where the amyloid increases at a rate of about 4% per year, which is also 4 centiloids per year. I'll explain centiloids a bit later on, until you get to the level found in Alzheimer's disease. So you can pick up amyloid about 20 years before the typical amount has deposited in Alzheimer's disease. And before this, there's probably another 10 years in which we can't detect the increase with PET. One of the problems with amyloid PET is that Alzheimer's disease is a very prevalent disease that goes up exponentially with aging. So if you start picking up the amyloid 20 years beforehand, you're going to find a lot of positive results in normal people. And this is data from the ABLE study of aging, looking at the percentage of healthy elderly people in a given decade of life who have a positive amyloid scan. So if you're in your 50s, about 3% of the general population who are cognitively normal have a positive scan. 10% if you're in your 60s, 30% if you're in your 70s, and 55% or more if you're over 80. Of course, the problem with this is that the main onset of Alzheimer's disease is in the mid to late 70s. So there is a risk of having a positive scan in somebody presenting with cognitive problems for another reason, such as depression, when the amyloid there is actually incidental. However, it's very rare to find a strongly amyloid positive scan in these asymptomatic people. And in fact, if this is a study again from Abel on the left, showing the survival over time, and this is in years going out to 7.5 years, of staying normal compared to developing mild cognitive impairment. So a measurable impairment on memory testing. And you actually need to have a moderate or high to very high amount of amyloid to really see people progressing to mild cognitive impairment within the first 6 years. After that, some of the people with mildly positive scans, which we define as 26 to 50 centiloids, were also starting to develop MCI. But by that time, remembering that amyloid's going up at 4% per year, they would actually have close to 50 centiloids of amyloid in the brain at the time of their progression. So a little bit of amyloid, so 16 to 25, and there's probably there's sparse plaques around, doesn't greatly affect your prognosis over 7.5 years. A mild amount does, but nothing much happens for the first 4.5 to 6 years, whereas having more than 50 centiloids, which is a moderate or more than that, high to very high, associated with much more rapid decline. The same in the risk of going from mild cognitive impairment to dementia. If you have a very high amount of amyloid in your brain, your progression to dementia is 50% in 2 years. If you have a mild amount in your brain, then 50% after 4 years. But if you have none or just a smidgen, there's virtually no progression over 4 years. Amyloid imaging has a bigger impact on diagnosis, and this is a study called IDEAS carried out in the United States in 18,000 individual scans funded by the US Medicare that was designed to assess the impact of this fairly expensive investigation. The concordance between clinical diagnosis and amyloid PET was quite poor. Those who came in with a clinical diagnosis of Alzheimer's disease, only 61% had an amyloid PET scan. Those with a diagnosis of another form of dementia or non-AD dementia, 55% actually had positive amyloid scans. After the amyloid PET result was released, in patients with a positive scan, the rate of AD diagnosis increased from 78% to 95%, and in patients with a negative scan, the rate of diagnosis decreased from 73% to 15% post-scan. So impact is significant, and this also further shows the shortcomings of clinical diagnosis. So how to read an amyloid scan with a colour scale. So rainbow scale is recommended for flutometamol, NAV4694 and PIB. Note that rainbow scales vary tremendously. Most have red at maximum, but some have white as their maximum. And the time and rate at which they progress through the colours is different. So this is a colour scale I like to use. It's fairly widely available. And I adjust it so that the cerebellar white matter intensity begins to become red, just a touch of red, or white if that is the top of a particular colour scale. This is done with PIB and NAV. It has to get substantially red if you're reading flutometamol, because this has a very high white matter binding. Setting the colour scale to the PONS is recommended by GE, but this will give a similar result. So in the illustration, the bottom left, we're just there. We're just starting to see a little bit of red appearing in the cerebellar white matter, to where the arrow's pointing. But on the right, the colour scale needs to be turned up. We're not seeing any red there yet, so there's insufficient blush of red in the cerebellar white matter. When you have your colour scale set correctly, this is what you see. So there's a negative scan on the left. Note the little arrows pointing to some venous pool blood activity. In the middle, we have a moderately positive scan, and on the right, we have a strongly positive scan. And I like to give my reports as mildly positive, or moderately to strongly positive. When you start, I've mainly used the axials, going from inferior cerebellum to superior. This allows checking that cerebellar reference to confirm you've got normal grey matter, white matter differentiation. There shouldn't be any plaques in the cerebellar grey matter, so you should just see the white matter. You check that to make sure it also serves as an internal reference for a negative cortical appearance. Corpus callosum should be well defined on the midline sagittal image in a negative scan, and check the interhemispheric fissure in the occipital and frontal regions. You can see here there's quite a wide gap between the hemispheres, apart from this little bit of venous blood pool activity. That's why I've pointed it out. Don't get caught by that. In this moderately positive case, that gap has closed up. And in the parietal regions, this medial parietal or precuneus cortex, you've actually lost the gap, and that's referred to as the hemispheres kissing. Review the sensory motor cortex. That is usually spared in both this moderately positive and strongly positive case. The sensory motor cortex is spared. Here's how to read floor-beta-per. As I mentioned, black on a white background. Adjust the grayscale to your preference so that the white matter binding becomes moderately dark. Review the white matter tracts for grey-white differentiation. Look for kissing of the hemispheres and smoothing of the cortex as it fills out. So this is a bit of a tricky one. This is borderline positive. You can still see white matter tracts, but they're starting to get blurred. And in the parietal cortex, it's going out to the edge here. So it's smoothing out. You haven't got the fingers here. So there's a little bit of parietal binding here. We don't see convincing kissing of the hemispheres. We go further down, we get an impression that the orbitofrontal cortex is smoothed out. So there's a little bit of binding here in the orbitofrontal cortex. And down in the lateral temporal regions, we're starting to lose that appearance of white matter, and we're seeing some smoothing out of activity in the cortex. So this is a mildly positive scan. Probably not enough amyloid to account for somebody presenting with significant cognitive problems. This is a floor beta bend scan. Red is white on black. The same rules apply when reading all these scans. Even you can read this one, floor beta bend, quite nicely as white on black, just like floor beta-per. There's no real difference apart from the manufacturers wanted to be different. So positive scan, again, loss of the white matter pattern. In this case, activity is clearly going all the way out to the edge of the cortex. You've got kissing here at the in the precuneus. The hemispheres are coming together. They're not clearly divided. The corpus callosum is not well seen. There's a little bit back here, but it's generally being lost because of activity in the adjacent cortex. There is good contrast between cerebellar white matter and grey matter. So it's a good quality scan. There's nothing wrong with the tracer. And if you compare the absent activity in the grey matter here with the activity you're seeing in lateral temporal cortex, it's clear that there's cortical binding of this tracer, and it's a positive scan. The corpus callosum can be useful. You need to look in the midline sagittal image. Ensure that this midline sagittal slice is not oblique, otherwise it will cut in to parts of the brain and make it appear that there's activity around the corpus callosum. When the scan is positive, you will usually see activity in the frontal lobe and back here in the posterior cingulate precuneus. And as the disease progresses, the corpus callosum disappears. In this case, it's a negative scan with the corpus callosum clearly defined. On the coronals, as I mentioned before, have a look at the white matter versus the grey matter in the sort of mid-cerebellar region and compare this to binding in the cortex. So you've got a floor beta per and a floor beta bend scan, both nicely demonstrating positivity by this criteria. Just one of several criteria that are used when reading a scan. This is a positive NAV4694 scan, highly positive. I'll just go through it as we go from the top. You've got frontal lobes, you've got parietal, you've lost the gap between the hemispheres, you've got a lot of precuneus posterior cingulate binding, you've got preservation or very little uptake in the sensory motor cortex. Patients with Alzheimer's disease don't become paralysed and don't go blind early on. The primary cortex, sensory motor and visual primary cortex, are quite resistant to the Alzheimer's disease pathology. And that's why they're also preserved on an FDG PET scan metabolically. Going further down, you can see the occipital cortex is relatively preserved. There is binding in the anterior striatum. In other words, the anterior part of the basal ganglia, predominantly the caudate nucleus, as you see here. You tend not to see this with floor beta bend or floor beta per, but you do see it with flutamidamol and PIB. Then we have binding in the lateral temporal cortex, and coming down into the cerebellum, we've got cerebellar white matter, but no binding in the cortex. So a nice, clearly positive scan. This is a negative NAV4694 scan. You've got wide separation from the hemispheres, a bit of activity in that superior sagittal venous sinus, in other words, blood pool activity. There's that finger-like projection everywhere. There's no smoothing out as you get towards the edge of the brain. And the colour scale is perhaps has got a little bit of red appearing, and so it's been set well. These are reading suggestions from radiographics. So I've borrowed this slide from that online resource from the RSNA. They talk about a tree in winter appearance in a negative scan and a tree in summer for a positive scan. So I like that analogy. They talk about kissing of the hemispheres, though in this instance they're showing anteriorly, but I personally think it's better seen higher up in the parietal precuneus area. In a negative scan, there's a bit of a diamond area here and a cartoon shape of the fingers of white matter in the frontal cortex. In a negative scan here, they talk about a double convex lens between the hemispheres, whereas in a positive scan, they come together. And when looking on the sagittal image, you can have a look at the striatum, and there should be a gap between the striatum and the brain, the white matter in the brainstem, but in a positive scan, it's continuous. But It's also extremely clear that there's amyloid everywhere else in this brain, of course, too. And you've lost that corpus callosum in amongst all the cortical binding. There are artifacts to look out for. Meningiomas, strangely enough, are strongly avid for all amyloid traces. Infarcts, prior hemorrhages and trauma result in defects. Normal pressure hydrocephalus is a bit tricky. Not infrequently, there'll be a referral. Is this Alzheimer's disease or is this normal pressure hydrocephalus? Well, unfortunately, amyloid plaques are frequently found in normal pressure hydrocephalus. There's often coexistent Alzheimer's disease, but there may also be impaired clearance of amyloid from the brain, resulting in it depositing into plaques. So you often see a mild to moderately positive amyloid scan, even in patients that respond to shunting with normal pressure hydrocephalus. Severe atrophy can give a false negative because the finger-like projections of grey matter mimic the finger-like projections of normal white matter when the brain is incredibly atrophic. This really is only a problem in severe, very advanced cases, and they're not the patients that are referred for amyloid PET. But they were to the post-mortem studies, so this was actually one of the reasons that the accuracy was only was not 100% in the post-mortem correlation studies. Poor tracer quality or rapid metabolism of traces results in vascular structures due to blood pool activity. And this is most prominent in the dural venous sinuses, superior and inferior sagittal and transverse sinuses, and is accompanied by prominent scalp and facial activity. But you can read through this in most cases and still come up with a confident reading of a positive or negative scan. Defluorination is relatively rare with these traces. If it occurs, you get uptake in the bones of the skull. And as always, patient movement can degrade image quality. Here we have a right parietal stroke in an otherwise negative floor beta bend scan, but it doesn't complicate interpretation. Here we have a patient with prominent activity in the venous sinuses, high blood pool activity. Here we have the superior sagittal sinus, the inferior sagittal sinus, and here the transverse sinuses, but also note there's quite marked facial activity as well in this person, and then in the jugular veins as they go further down. This one has a bit of uptake in skull, but it's still clearly a positive scan, activity in typical areas. On that previous one, despite this blood pool activity, it was still clearly a negative scan, good gap between the hemispheres, no smoothing out of cortical areas in any area. A scale has been developed that can quantify an amyloid scan into a 0 to 100 scale. It's called the Centiloid scale. It's analogous to the Celsius temperature measurement from 0 to 100, where the temperature at which water freezes was set at 0, and where it boils, it was set at 100. The same thing's been done here with an amyloid scan. 0 is what you find in normal persons under the age of 45 who won't have any amyloid, and 100 is what the scale was set to with the findings typical of mild to moderate Alzheimer's disease patients. This scale overcomes the differences between the traces, and it gives you thresholds that can be applied at different sites. It enables comparison not only across different traces, but it helps to confirm visual reading, increasing diagnostic confidence, and it provides a more standard assessment compared to what up until previously were individually derived in-house SUVR measurements. So as I mentioned, the scale is 0, set at 0 based on the scans done in normal persons under the age of 45, set to 100 in patients with typical mild to moderate Alzheimer's disease. It uses a whole cerebellum reference region and a single large cortical region of interest that was tailored to the areas of brain accumulation in Alzheimer's disease. This creates an SUVR of cortex to cerebellum, and this is converted to a centiloid value using a linear equation that's been derived for each tracer. And the data, this was published in Alzheimer's and Dementia, and also in the Journal of Nuclear Medicine back in 2000 and I'm forgetting now, I think 16. All the data required for implementing the centiloid approach at your institution is available through the Global Alzheimer's Association Interactive Network, but you will require the help of a physicist or a image analyst specialist. Centiloids have been compared to post-mortem. Less than 12 centiloids indicates no amyloid plaque. Greater than 25 correlates with neuropathology findings of significant plaque, moderate to frequent in number by what's called the CIRAD classification. And greater than 50 correlates best with the full neuropathological criteria being met for Alzheimer's disease. And so this is the presence not only of a sufficient amount of plaque, but also of tau tangles of sufficient number and density. So a threshold of 25 is used to define a positive scan. Sometimes 20 is used as the threshold, but a threshold of greater than 50 best supports a diagnosis of Alzheimer's disease. Centiloid values increase, as I mentioned, by about 4% per year and then plateau in the dementia phase. CSIRO here in Australia have made a program in collaboration with the ABLE study. It's called Capable, and this can take an amyloid scan and quantify the amount of amyloid on the centiloid scale without requiring an MRI. It's available to researchers upon application. The turnaround time is about 1 week. As I mentioned, the game website includes all the instructions you need for setting it up in your institution on available equipment, but you do need MATLAB and you do need the patient's MRI to use this approach. Fortunately, many PET cameras and independent nuclear medicine software creators are now coming up with programs that generate a centiloid result, making it much more accessible. So that's the end of this part. This is the recommended reading. In part 2, I will present cases for you to read blind and then present my reading along with the centiloid result at the end. So thank you for your attendance.